Hello everyone, I'm Jill Stoll, a partner in the health litigation team in Hill Dickinson's Liverpool office in the health litigation team. And I'm going to give an update today on the duty of candour. This is, of course, the duty to be open and honest with patients as soon as possible after a patient safety incident has occurred. It is the morally right thing to do, but it's also a legal requirement of all health providers. I'm going to start with a brief reminder as to the background of the duty, and then I'm going to look at the different types of candour, but I'm mainly going to focus on the statutory duty, looking at the latest CQC guidance. And I'll discuss some of CQC's worked examples to see how the duty is intended to operate in practice, with some tips about how to discharge the duty and what the focus should be at board level. Many of you will know that the duty of candour came about following the Mid-Staffordshire inquiry in 2013. Sir Robert Francis Casey called for a statutory duty of openness, transparency and candour in the NHS. There were a number of reports commissioned subsequently, including Patients First and Foremost in March 2013, the Berwick Review in August 2013, and Building a Duty of Candour, Dalton and Williams in March 2014. And this all culminated in the statutory duty of candour. It's all about the need to proactively report patient safety incidents to patients, whether or not they ask about them. And it should be seen as an opportunity to learn from errors and improve services. There is a professional duty to be open and honest when things go wrong in healthcare, including explaining and apologising to patients. Now, that is a much wider duty than the statutory duty, and it applies irrespective of the level of harm. And it's overseen by regulators such as the GMC and the NMC, who've published guidance and subsequently updated that guidance. And the links will be made available to you after this session. And of course, there's the statutory duty that I'm going to focus on today, which is one of 12 fundamental standards of safety and quality below which care should never fall. It was introduced by the Health and Social Care Act 2008, Regulated Activities Regulations 2014, so a bit of a mouthful. But it's been applicable to all NHS bodies since the 27th of November 2014, and it was extended to all CQC registered providers from April 2015. So it's been around for quite a while now. So what is the duty? Firstly, there's a general duty to act in an open and transparent way with patients. Again, you see the repetition of those key Francis notions. And secondly, there is a specific duty which, once triggered, sets in motion a process or series of steps and actions which must be followed. The specific duty is triggered where there is a notifiable patient safety incident, and I'm going to look at that definition in a moment. And it requires a formal response. In that, the relevant person must be notified of the incident and they must be provided with reasonable support. Now, I'm going to come on to talk about discharging the duty in a bit more detail shortly, including how to notify, considering who the relevant person is and what reasonable support might look like. So a notifiable patient safety incident is a specific term defined in the regulation, and it shouldn't be confused with other types of incidents and notifications. It has to meet all three of the criteria on this slide in order to trigger the statutory duty, but it's really important to remember that if it doesn't, there's still that overarching general duty of candour to be open and transparent, and also the professional duty. So there must have been an unintended or unexpected incident, which must have occurred during the provision of a CQC regulated activity, which, in the reasonable opinion of a healthcare professional, already has or might result in one of the harm thresholds being reached. For health service bodies, so that's NHS trusts, NHS Foundation Trusts and special health authorities, the harm thresholds are as shown on this slide. So you've got moderate harm. That's harm that requires a moderate increase in treatment, and significant but not permanent harm. A moderate increase in treatment has been defined within the regulation as an unplanned return to surgery, an unplanned readmission, a prolonged episode of care, extra time in hospital or as an outpatient, the cancelling of treatment or the transfer to another treatment area such as ICU. Severe harm, but easier to spot, has been defined as a permanent lessening of bodily, sensory, motor, physiologic or intellectual functions, and they give the examples of removal of the wrong limb or organ or brain damage. But of course it must be related to the incident itself and can't be due to the natural course of the illness or the underlying condition. Prolonged psychological harm, and that's for a continuous period of at least 28 days, and then of course death. The definitions of harm do vary slightly between providers. So these are the thresholds for organisations other than health service bodies. So again, you've got death, you've got impairment of sensory, motor or intellectual functions, which has or is likely to last for at least 28 days. Changes to the structure of the body, prolonged pain or prolonged psychological harm, shortening of life expectancy, or requirement for treatment to prevent the adverse outcomes listed above. So what I'm going to do now is drill a little deeper into some of the terminology around a notifiable patient safety incident. Firstly, the incident has to be unintended or unexpected. The latest CQC guidance says you shouldn't interpret unexpected or unintended with reference to the outcome or with reference to the harm which has occurred, but assess whether an incident has actually arisen in the course of the regulated activity. This doesn't mean that known complications or side effects of treatment are always disqualified as notifiable safety incidents. Something can still qualify, even if the patient gave consent for a procedure to be carried out and a known risk then materialises. It all depends upon whether or not something unexpected or unintended has happened during the treatment or care. The case studies will hopefully bring that aspect to life a little bit more shortly. I just wanted to touch as well on near misses, and the CQC guidance specifically excludes these. However, if the expectation is that the patient will suffer harm, even if that hasn't materialised yet, or where the full extent of the harm isn't clear, but it is likely to fall into one of the harm categories, then the duty will be triggered. Okay, so let's look now at some worked examples. So firstly, a mental health example. A prescribing error on a mental health ward resulted in a detained patient being given double the dose of lithium for several days. So that's double what she normally receives. She then develops lithium toxicity, which requires inpatient treatment, and she makes a full recovery. So then, in order to ascertain whether or not a notifiable safety incident has occurred, you have to go through and ask those 3 questions. So did something unintended or unexpected happen during the course of treatment? Yes, you've got a patient who's been given the wrong dose of her medication. Did it occur during the provision of regulated activity? Yes, it occurred during the provision of medical treatments for persons detained under the Mental Health Act 1983. And has one of the harm thresholds been reached? Yes, the incident resulted in moderate harm in this case. So you've got significant but not permanent harm and a moderate increase in treatment. So because all of the answers are yes, this does qualify as a notifiable safety incident for the purposes of Regulation 20. And so all of the steps required by the formal duty of candour have to be carried out. The next one is a care home example. So you've got an occupational therapist who completes an assessment with a care home resident whose mobility was deteriorating. They advised that grab rails were needed in his bathroom before it was safe for him to use the bath, and that in the meantime, staff should assist him with a wash each morning. However, the manager fails to update the man's care plan or inform the care staff of this change, and so staff supported him to have a bath in the usual way. He then slips, unfortunately, whilst getting out of the bath and breaks his arm. The arm was put into plaster cast and the man needed full assistance for all aspects of his care for 6 weeks until the cast was removed, but he does make, thankfully, a full recovery. So again, going through the same process, have you got something unintended or unexpected which has happened? Yes, the man slipped whilst he's been getting out of the bath, whilst the occupational therapist's advice hadn't been followed. Did it occur during regulated activity? Yes. It's occurred during the provision of nursing or personal care. And has it resulted in harm? Well, yes. You've got an injury which has occurred, in this case, a broken arm, and it would fall under the definitions applicable to the care sector. So again, the answers to all 3 questions are yes, and so you need to follow the formal duty of candour process. Now on to a surgical example. If we just go through that one, we've got an elderly woman who undergoes a coronary artery bypass operation. The operation is carried out according to plan with no unexpected or unintended incidences, but the woman suffers a large stroke during the operation and sadly dies soon after. So again, have you got anything unintended or unexpected? Well, until the more recent CQC guidance, we would probably have said yes, because until you've carried out investigations, it's very difficult to know if there had been an incident which had occurred, which caused the stroke, rather than it just being a recognised complication and one of those things. But the CQC have said, for this example, no, there isn't anything unintended or unexpected which has happened during the course of the treatment. Now, this really does rely on a judgment call of the clinicians involved. So it's very important in our view to make sure that there is a careful assessment if you're going to rule out invoking the formal duty of candour. But if we just follow that through for completeness, did it happen during provision of regulated activity? Yes, it's during the provision of surgical procedures. And has one of the harm thresholds been reached? Yes, in this case, sadly, death. But because one of the answers is no, overall it doesn't qualify, as I say, as a notifiable safety incident. But again, you do have the overarching duty of candour to be open and transparent about what's happened, which always applies. And you've also got the professional duty as well to keep in mind. Okay, so if we move on now to talk about discharging the duty, CQC guidance states that you must start the specific procedure which has been laid out within the regulation as soon as reasonably practicable. And they say that has to be within a maximum of 10 days following the incident, but we would advise trying to do that sooner. Any delay or wall of silence or people feeling that they're being fobbed off whilst an investigation is conducted is only going to detract from the candid explanation once it's eventually given. You are required to tell the relevant person face to face that a notifiable safety incident has taken place. So it's really important as well to think about the softer element of that. So really planning the meeting, thinking about who is best placed to discharge the duty. Now that will usually be the most senior person involved in the patient's care, but it is case specific. So considering who the patient actually wants to hear from, if maybe there's been a breakdown of communication along the way, or perhaps thinking about who has the best communication skills. Also just thinking about who is going to be attending the meeting and letting the family know beforehand. So thinking about the location and the time and the date and whether there might be an access issue to overcome. And also the little things which really do matter. So is there any tissues and water available and that type of thing. These meetings can be very daunting for patients, so it's a really good idea to make sure that staff don't forget to introduce themselves and say why they're there. It's important to provide a true account of what's happened, explaining whatever you know at the point in time that you're having that meeting. So it doesn't matter if you don't know all of the detail at that stage. It would make a nonsense of the process if you had to wait until you have the full details before having that discussion. To fulfil the duty of candour, you have to apologise for the harm that's been caused, regardless of fault, from the start. And people panic about this, but it's just a simple, straightforward expression of sorrow and regret for the harm that's been caused. So just a human reaction to the situation. It's crucial to give an effective apology, which is all about meaning it, and people can easily tell the difference if you don't. So it's crucial to be clear and concise about what you're apologising for. Language is important, so avoiding things like "this was negligent," and it's much better to use phrases like "this shouldn't have happened," or "I'm very sorry that you've come to harm whilst under our care." It's good to say what's happened and why, but an apology followed by an excuse isn't really a good apology at all. So just thinking again about the language used. And follow up by explaining what you're going to do about it and giving the patient and their family the chance to respond and to ask questions. And again, responding to those questions honestly. Make sure that staff who are going to be attending these meetings are aware of any lesson learning. The more you can include about the learning which has been implemented or will be implemented, the better. What has changed following the incident? How do you know it won't happen again to someone else? And explain what you're going to do if you need to carry out further investigations and the timescales for those investigations. Then follow up in writing. It's really important to document everything so you have a note of all questions from the relevant person and that action points are agreed and minuted. And crucially, that you follow through with the investigation and report back. Of course, there are going to be occasions when the relevant person can't be contacted or doesn't wish to communicate. And the CQC guidance makes it clear that those wishes should be respected, but you must keep a record of that fact. You've still got to report the incident and you've still got to investigate it to make sure that harm doesn't happen in other cases. And finally, it might also be that incidents meet other notification thresholds, so just having a think about that too. Let's talk now about who is the relevant person. And it's important, of course, to establish that at the outset so that you're having conversations with the right people. Usually, it'll just be the patient themselves, nice and straightforward. But where the patient has died or is over 16 and lacks capacity, or they're under 16 and they're not competent to make their own treatment decisions, then it can be anyone lawfully entitled to act on their behalf. And the usual rules about capacity and competence apply. If the relevant person consents, the CQC would expect to see that you have involved family members and carers in any discussions. And it's all about taking reasonable steps to make sure that you communicate in a way that is accessible and as accessible and supportive as possible. There is also a duty to provide reasonable support to the relevant person, and this isn't prescriptive, but the CQC have suggested the following. So you might want to think about environmental adjustments for someone who has a physical disability, an interpreter for someone who doesn't speak English very well, information in accessible format, so thinking about that side of it, whether you can signpost them to mental health services or provide the support of an advocate, and just drawing attention to other sources, so maybe AVMA or bereavement support and that type of thing along the way. Now, I just wanted to touch briefly on the impact on claims. NHS resolution, as many of you will know, provides indemnity for most NHS organisations and some private organisations as well. Their role and ours as one of their panel firms is to investigate and respond to claims and pay compensation out in the right cases. We want to get to the bottom of whether there's any liability, and if so, what the claim is realistically worth, so we can minimise costs and settle those cases where it's appropriate as soon as possible. Claims are a very expensive process. The NHS resolution pay out billions in damages and legal costs every year. But they want their members to acknowledge when things haven't gone to plan, and they want them to try and identify learning so that they're improving future outcomes and patient safety generally moving forwards. So we reduce harm and in turn reduce claims. They wholeheartedly endorse the need to be open and honest with patients about mistakes. And I think in the past there was a genuine concern that saying sorry for something would open you up to a claim. But NHS Resolution have made their position on this really clear. So they have said saying sorry is always the right thing to do. It's not an admission of liability. It acknowledges that something could have gone better, and it's the first step to learning from what happened and preventing it from recurring. And Helen Vernon, Chief Executive at NHS Resolution, has said in direct terms, we have never and will never refuse cover on a claim because an apology has been given. So there's loads of reassurance there. Research suggests that absent, delayed or poor communication with patients and their families will make it more likely that they're going to seek information via the claims process. Patients do genuinely often just want to know if something went wrong and what's going to change to stop it happening again in the future. So being open and honest at the time that care is provided in accordance with the duty of candour can actually prevent claims. But obviously just don't go further than you can based on the information available at the time. You know, if an investigation needs to happen before you can go into more detail, then just making sure that you hold off providing further information until that's been concluded. Now, the CQC will assess compliance with the duty of candour when they carry out their inspections to ensure providers are creating an environment that encourages candour, openness and transparency at all levels within the organisation. They want to make sure that providers are learning from incidents and improving care. Now, the key, I think, is making sure that you've got the right training in place, policies and systems to really empower staff to do the right thing. The CQC wants to see commitment from the board down. So it's important to show that the board has a handle on how the duty of candour is working in practice, who is monitoring compliance, and does the organisation address any pockets of non-compliance. They will investigate specific notifiable safety incidents where they have concerns, and there have been convictions. The fines aren't significant, so we've seen fines up to £2,500 per case. But of course, the real risk here is reputational damage. And this really is exactly the type of thing that the media love to report. There is a narrow defence available, and this is where providers have tried to make contact with and speak with the relevant person and follow the process, but they haven't been able to, or the person has refused. And so it's really important, again, just to reiterate that those efforts need to be documented. So you've got that if the CQC ever ask. So in summary, if in doubt as to whether the duty of candour is triggered in terms of the formal statutory process, my advice is to err on the side of caution and trigger the process and seek advice. Don't get too hung up on, which level of harm applies or whether an incident is, unexpected or unintended, because you just might get caught out. Nothing stops you following the process if you choose to do so anyway. And don't forget the professional duty or the general duty to be open and transparent with patients, even if the statutory duty doesn't apply. It's important to engage with patients and have open and timely discussions. Give as much information as is known at the time, using lay terms so they can follow and understand. But don't speculate on unknowns until the investigations are fully concluded. Keep good records to evidence the steps taken, particularly the verbal and the written notifications. And remember that an apology is not an admission of liability or fault. It's just an apology for the harm that the person has suffered. And overall, really try to encourage a culture of candour within the organisation. Make it clear to all staff that it's the right thing to do and that staff are actively encouraged and supported to fulfil the duty. So if you do have any questions on this session, please do get in touch. Pop to my email address on the screen. Thanks everyone.